Hello, I'm your host, Dr. Kelly Cleary, the Senior Director of Education and Support Programs for FAIR, Food Allergy Research and Education. And I'm excited today to be joined by Dr. Barbara Yawn, adjunct professor in the Department of Family and Community Health at the University of Minnesota in Minneapolis. So welcome, Barbara.
Thank you. I'm looking forward to this.
Same. So, thanks for joining me. Let's get right to it and get started. Can you briefly explain the underlying pathophysiological mechanisms of IgE-mediated food allergies for us?
Well, in very broad terms, we have learned actually quite a bit in the last few years. We now know that for food allergies, we're talking about first exposure, obviously, and this is usually through the gut. And we know that some of these particles of the allergen, the food, get through the gut wall and make it through the microbiome and other things and into the area around and into the bloodstream. And then we get a reaction to this allergen, and what the body says, oh, that's not an allergen I'm tolerant to or accept. And so you have the things such as TSLP, IL-23, IL-25, the mast cells. You have the eosinophils, basophils, other things like, as I said, the mast cells that produce excess uh, things that lead to inflammation and the symptoms. So, why does one person have it and another not is a really very interesting question. And yes, environment, genetics, but there are probably other things that we don't even know about yet.
Yeah, and I think that's so interesting, not to date myself, but I remember being in elementary school and not knowing anyone that had a food allergy, and now recognizing that almost two students in every classroom have a food allergy. So you mentioned some genetic and environmental factors that may be in play, but why else do we think that there's such a rise in food allergies right now?
Well, some of it we don't know, but also some of it has to do with different hypotheses, like the hygiene hypothesis, for example, because we don't expose infants and children to as many things as at a very young age, then they may not become tolerant to them, and we may have more. There are all kinds of other hypotheses, and I mean, the answer is we don't really know, but do things like irritants and uh, the environment and things that are not food, but do they add up? Do you have a reaction to one thing and then we add, and you're probably okay with that, but we add a second or we add a third thing, and all of a sudden you react adversely to several things. Do you have other things that you think are causing this increase?
Yeah, definitely. I mean, I think, as you said, it's multifactorial. I think no one really can pinpoint one answer. The hygiene hypothesis has certainly been one that I think has received a lot of, attention throughout the years. The dual allergen hypothesis, as you mentioned, that I think that that whole entire shift in prevention of food allergies and the LEAP study have really opened our eyes up to some of those immunological mechanisms for the start of food allergies. But I know that there's so many others, whether it's in the microbiomes, vitamin D deficiency. So lots to consider. And I think whenever I'm asked that question, I always just say multifactorial, and we're trying to pinpoint the answer there. So but until then, the hygiene hypothesis, I think, still gets a lot of clout in that. So it's always mentioned when asked.
I think so, and but I also think that the dual allergen is really important as we get exposed to more and more things that are not only allergens, but also irritants. I'm gonna be interested if it's not just dual allergen, but dual allergen and irritant that causes this increase, because as you pointed out, there has been a really large increase. Now, maybe some of it was we didn't recognize it and our patients didn't come in and tell us about it. They just quit eating peanuts, or they just quit eating seafood or whatever it is, and we never made the diagnosis. So that might be part of it. And I'd like to hope that's part of it, because that would suggest patients and families are more aware, and that I, as a physician, am more aware and take it seriously when someone comes in and tells me they're having problems.
And I think even just the shift in what we've learned through medicine throughout the years. I know, when I was in my pediatric residency 15 or 20 years ago, the guidance on feeding food allergens was very different than it is now. And all of that, really does have to do with the theories between cutaneous exposure and, oral consumption. So I think now the guidance of prevention and, it really encouraging families to feed early and often for food allergies once that baby is developmentally ready. I think we may start to see a change in the landscape of incidence and prevalence. So I think lots going on there. But to shift gears just a tiny bit, let's kind of focus a little bit on your clinical practice. And when you have patients coming in that you do suspect maybe have a food allergy, what are the tests that you're ordering to confirm that diagnosis of an IgE-mediated food allergy reaction?
First thing, I'm not going to jump to tests, and I know you don't in your practice either. I really need a good history. And this is something that, as a primary care physician, hopefully this is one of my important roles, is getting that very clear history. What food was it? How often? How much? How quickly after? What symptoms did you have? All of those kinds of things, and actually being very specific if I can. If someone comes in and said, "Oh, I have a reaction to seafood," well, seafood includes several things. So, are we talking fish? Are we talking mollusks, which have the shells on them? Are we talking crustaceans, which have a different kind of shell? So, all of those kinds of things. Once I have pinned that down, hopefully for most people, we're talking about a few things. We're not talking about 20 things. And then I need to decide whether or not, as you said, is this an IgE mediated food allergy? Because that makes a difference in the therapy. So I'm going to order some specific IgE testing. And there are tests that are specific for shrimp, for example, or peanuts or lobster or various things. And I don't want to order one of those panels, because the panels have 20 things in them. And if you test for 20 things, one or two are going to come back and they don't fit with the patient's history at all. So I try to be very specific. Now, I don't do skin testing in my practice. So if the IgE testing, the specific IgE testing, is very suggestive, and this is not an anaphylactic and it is something that's easy, I may end there and talk about how do we avoid that, whatever thing it is. If not, I'm going to send on to my allergy colleagues, because they're going to do the skin testing and the food challenge. I can't do a food challenge in my office. I don't have the staff. I don't have the any of the things you need, but those would be the first. I think the first are the blood tests and being very specific, then the skin testing, and then finally, if you need it, the food challenge.
And I think that that's so important that you highlighted just the weight that the clinical history really plays in this, because even as you're saying in the management, what I'm hearing from you of your own patients is that if the clinical history is strong enough, plus the initial blood tests are, consistent with an IgE mediated food allergy, that you are, treating within your practice and, telling those patients about avoidance, but any sort of question in that, and then that's when it seems like you're referring. Is that correct?
Absolutely correct. And also, if I have someone that, as I said, has one or maybe two things that I think they can pretty easily avoid, and I have the time and ability to do that education about reading labels and all the other things that are really important, I can handle that in my practice. But if I have somebody who had a pretty severe anaphylactic reaction, if they have it to multiple foods, if I really am not quite clear, I need my colleague to help. And allergists not only can do those testing, they frequently have people in their office that can do a better job and a more thorough job of education than I can, or my staff, who that's not their area of expertise. So I also really sometimes say, hey, can you just give me a consultation, maybe one or two visits to help with these aspects, not just of testing. Please confirm you agree, but then help me with avoidance and education and all those kinds of things.
And you are right now, speaking my own language as the senior director of education at FAIR. I mean, that I think is some of the most important things in guiding patients who are newly diagnosed, because most of what your guidance is how to avoid, how to be able to dine outside of your home, how to read a label, how to convey your allergies, in a way that really signifies how severe they are. So I think that's a great source to think about how you're going to educate your patients best. I have a question for you. In these past few years, are you seeing more adults being diagnosed with food allergies?
Yes, absolutely. I mean, when I was on one of the national food allergy guideline panels, and we spent almost all the time talking about children because we expected it to be infants and children. But you start realizing you have not just 25-year-olds, but I have 45-year-olds coming in and saying, well, I thought I could eat whatever it is, but now I'm having a reaction, and they're clearly having a reaction. You go on and find out that indeed their testing is also abnormal. And so this is really fascinating. Did they develop a new intolerance? And it's not intolerance, it's truly an allergy. Did they develop a new allergy? Or is it this dual hypothesis that we added one or two things? Or have they always had it and they just never noticed the symptoms, or the symptoms are worse? I'm not totally clear about whether it is new onset at 25 or 45, or it is just worse and now we're aware.
I'm interested to see in the years to come where the research and science, gives us some more clues on adult onset and really the mechanism of action and how it's happened. Do you find clinically that you're treating a pediatric food allergy patient any differently than an adult onset food allergy patient?
Well, I am, because they do have different, most common allergens. And I know also that there is the ability in, especially infants and young children, to potentially get them to the point of tolerance, so we don't have to worry so much about an accidental food exposure, which, as you pointed out, they go to school and all kinds of things may accidentally be exposed. So yes, I am treating those. I'm thinking much more about therapy beyond just avoidance, potentially, for those kids. And also tolerance. We now know that there may be the ability, in a family, for example, that has a lot of problems with food allergy. Instead of me saying, well, let's breastfeed this baby until they're 12 months old, I may say, let's breastfeed, uniquely and nothing else until maybe 4 or 6 months. And then let's talk about introducing some other things slowly in small amounts. So I think, yes, I do have a different approach. And obviously, there's a hugely different approach to education when you're educating a child or an adolescent versus an adult. The child and adolescent, you absolutely have to include the family, but some point, you have to change from the family focus, maybe in an infant, to the adolescent focus they're in control of their life, and I want to make sure they know I know that we should make the decisions. And the adult, yes, don't forget their family, by the way, because that may be important too, but that's different.
Yeah, and I think that that's so important, just in the guidance as a physician that we're giving patients at all the different stages in their lives, because I'm a food allergy mom, and I think that the guidance that is given early on is really, to that parent, and how do you teach within your actions about keeping your child safe. But then very quickly it becomes, how do you teach that patient to advocate for themselves and always carry their epinephrine. I think that for young adults, and adults, beyond, is so important.
You said something we really need to stress. You get them to carry their epinephrine auto injector. We need to make sure the patients and their families understand how crucial this is, that they have it and they have two and they're up to date. And they're easy to use. I mean, I don't think many people who've ever used one are frightened about using it again in the future. They really are simple to do, and they can be life-saving.
And you mentioned, sometimes patients perhaps being frightened with the medication themselves, or maybe, having anxiety or fear just related to food allergies themselves. In your own practice, is there, some interprofessional approach with, dealing with some of the psychosocial aspects of food allergy, or is that something that you rely on when you're referring patients as well?
Mental health concerns have always been a big area of my interest. And so we have people in the practice. I have a psychologist right down the hall that I can do a warm handoff to, literally, introduce them. And I think that helps, whether I make that handoff over the phone or through an email or whatever. But I think letting my patient know that this is a real concern. And in addition to treating the food allergy, there may be other ways to deal with anxiety symptoms. And let's talk about how we do that. So I don't like to have to say, well, why don't you go see somebody about it? I just don't think that's very effective. If the allergist that I refer to, I know they have somebody in their practice and somebody they work with, I might say, you can see them too, but I want to make a very specific referral for that because it is a huge problem.
And I think it's amazing that you're able to address it within, your own practice, and have a psychologist nearby for that, because I agree with you. I think that the psychosocial impact, is really, affecting quality of life for patients in the food allergy community. Anything else that we haven't touched on?
I think that knowing that there are groups like FAIR is really important, because before I started working with you and others on this, I was not aware of FAIR. I had not found it when I pulled it up. So thank you for doing it. And I know you have resources that are very useful and important. And as a primary care physician, I need all of the reliable resources I can find. And so you're now right on that list. So thank you.
Well, thank you, Barbara, for joining me today. I think, in summary, we are, recognizing that food allergies are on the rise, and it really sometimes does take an interdisciplinary team to not only diagnose and treat, but also to just think about the patient as a whole. So I thank you for this great conversation, and for all that you're doing for your patients.